share our experiences. Thank you very much, Gilbert.
No, fantastic. Good to see you. And Andrew, I'm sure we've met before, Andrew.
Yes, we've.
Your name, the Kakaka. We've met before. Before we finish the 1.5 hours, I will find you. We probably met somewhere in South Africa or somewhere on the continent. But Africa has become very small. Africa has become very small. Yes. Okay. So Elom, NS is on the line now, but if you can introduce yourself and then put him on as a panelist, and then he can also join us. Elom, you may want to unmute. We can't hear you. Elon, we still can't hear you. So, Ernest, kindly put yourself on video so that we can see you. Ernest, if you are able, kindly join us on video as a panelist so we can all see you.
Yes, I'm here.
Okay. Good to see you.
Yes.
Now, Ernest, you see, you've got the light behind you. We can't see your face. You know, we're all Black Africans here. When the light is at the wrong place, we don't see anything but white ice. Okay.
I think it's much better now.
It's much better. If you could introduce yourself.
I'll reposition myself in the office. So, yeah. Okay, maybe it's better.
This is much better. Fantastic.
Yes.
Good. So if you could introduce yourself to us, that would be extremely helpful.
Okay. So my name is Ernest Kunedu Esiedu. I'm the quality manager of the Ministry of Health in Ghana.
Okay. Most welcome. Elom,
thank you.
Elom, can we hear you now? No, we still can't hear Elom. We still can't
Elom
hear
must unmute.
Yes, Elom, I tried to unmute or you've unmuted. Okay. We still cannot hear Elom. Well, Elom is the technical director of AfIHQSA, and jointly we will facilitate this process. So ladies and gentlemen, colleagues in health, you're all most welcome to this morning, afternoon, evening session. It is designed for 90 minutes. We have three very experienced individuals. Margaret from Sierra Leone. Wave at us. Yep. Andrew from Malawi. Andrew, wave at us. Don't be too serious. Wave at us. Andrew. And NS from Ghana. Okay. So charity begins at home. So yes, Ernest. Our participants in their various roles as national quality managers will share with us their stories of the situation of how quality is rolling out in our various countries, how our clients, our patients are experiencing or not experiencing quality, what efforts at the national level they are putting in, and how they are going about rolling out the quality agenda, and what is on their heart that they would wish to see in their respective countries. So I will now ask Ernest to take over. He will give us his heart for the next 15 minutes. I will ask the other panelists to go off video and go on mute. And Ernest, all yours. We will prompt you when it's time. Thank you very much.
Thank you very much, Gilbert Bakel, for this opportunity. And I also want to thank AfIHQSA for the opportunity to talk a little bit about Ghana. I'll just be waiting for Elom to give me the opportunity to share my screen. And generally, I would start with some background information about the situation within Ghana, some of the quality-related issues.
Okay, so Ernest, you can share your screen. You have the facility to do that. As a panelist, you have the facility, so you can go ahead and share directly from your end. Great. Okay. Thank you. Fantastic.
Thank you. Okay. For some strange reason, I put the coat of arms there, but I don't know, it's not showing. So generally, I will be talking about a bit of Ghana's efforts, the initiative, the challenges, and the way forward. So by way of outline, there will be a bit of some background information and introduction, overview. I'll talk a bit about the National Healthcare Quality Strategy, look at a few performance indicators, some achievements and challenges, and then the way forward. So I just want to give a bit of background information about the situation of the health sector in the country. And I'll say that the Ministry of Health takes its mandates from the Civil Service Law 1993, which is the PNDC Law 327, that develops and coordinates relevant health policies towards effective health service delivery, and then also monitors and evaluates the various implementing activities that happens. And of course, it's also by law, the directive principles of state policy. And then we are saying that the health of the Ghanaian or any person living in Ghana is also a right. And for which reason, the ministry's role typically will look at policy formulation, monitoring and evaluation, and also mobilizing resources within the health system. But typically, we also have the service delivery agencies, the Ghana Health Service being the largest, and then also 5 teaching hospitals that are established by an act of parliament that runs services within the country. In addition to that, we've got also the Christian Health Association of Ghana and Ahmadiyya, which are the faith-based institutions. We also have the quasi-health institutions, that is the health facilities that are owned by other ministries other than the Ministry of Health. Of course, they take their mandates and they also implement under the related issues and as far as health is concerned. And then we also have the self-financing private sector institutions that also provide this in the country. So the ministry is committed to putting in place through these policies as a health system that focuses on the following. So as part of the Sustainable Development Goals and the universal health coverage, Ghana has a roadmap that focuses on 7 areas other than the 5 that globally we are looking at, that include health promotion, health prevention, curative care, rehabilitation, and then also palliative care. But in addition, because Ghana has defined universal health coverage as the quality in terms of access, timely access to high quality service without any financial barrier at the point of the services, we have at emergency services as part of the timely care that we want to provide, and then also focus on the mental health illnesses that we have simply because of the stigma and the discrimination. But this is also well integrated into the other 5 areas that we are looking at. In addition to this, we also want to state that the ministry, as it's there, has 24 implementing agencies, in addition to the development partners, and then also other relationships that occur as far as laterally relate other ministries, departments, and agencies. And like I mentioned, we have some other facilities that do not necessarily belong to the Ministry of Health, but other ministries that also provide health services for their staff, and then also by extension to the rest of the population. But I think I just want to mention that the emergency services and support services are also a critical part of the service deliveries that we activities that we have in the country, and then AIDS regulators, and then trainings, which looks at both public and private, and then our major health financing activities, the national health insurance, in addition to some other private health financing schemes that are also around. The major or the largest service delivery agency is the Ghana Health Service. Again, a bit of a focus on the Ghana's health system, which is pluralistic, looking at both the public sector and the private sector. It focuses also on orthodox settings in the traditional and alternative medicine, for which reason we have a regulator called the Traditional Alternative Medicine Practice Council, and then also we have the Traditional Alternative Medicine Directorate in the Ministry of Health. We also have the Center for Research into Plant Medicine that researches into herbal medications that we can use. And the Food and Drugs Authority is responsible for regulating the practice as far as the use of these medications are concerned. Now, zooming a little bit into the space of quality in the country, we have had what we call the National Health Quality Strategy that piggybacks on what we had already had, between 2009 and 2015, working on Project 5's Allies, in addition to many other interventions within the maternal and newborn and child health space. And this National Healthcare Quality Strategy was launched in 2016. It's a 5-year strategy from 2017 to 2021. So clearly you would see that we are in our 4th year, and next year becomes the last year where we're going to review and look at some of the issues that we need to amend and things that we need to add on to, or things that we need to take up. But as I mentioned, getting all the agencies on board, including regulator, service delivery, the establishment of the quality management unit within the Policy Planning, Monitoring and Evaluation Directorate of the Ministry was done. And that is actually coordinating the operations of the implementation of the National Healthcare Quality Strategy. The National Quality Technical Committee becomes the secretariat of the implementation, and then the members are drawn from each of the agencies, and these are technical representatives. And then typically, the National Quality Technical Committee is chaired by the chief director, but operationally the oversight is done by the director, policy planning, monitoring, and evaluation. So generally, it coordinates another platform as far as the involvement of the community is concerned, which we are using what we call the community platform or the community scorecard. And then this looks at a number of quality and safety initiatives within the system. Again, just to focus a little bit on what the National Quality Technical Committee does, because this was inaugurated and ultimately into another standing committee, which we call the Interagency Leadership Committee. This committee is chaired by the Honorable Minister for Health, and it gets its membership from representations of all the agencies, that is the heads of all the agencies within the agencies of the ministry. And I would say that it becomes the highest decision body of the Ministry of Health. And most of the time, the technical decisions that are taken at the National Technical Coordinating level, quality will be packaged to the Interagency Leadership Committee for them to take the final decision for its implementation. So I'd like to talk a few just about some achievements that we have talked at the period. We have what we call the quality governance structures as proposed by the Strategic Objective 1, currently established across all the agencies. The Health Facility Regulatory Agency, which was also established by an Act of Parliament in 2011, which has the responsibility to license both public and private facilities to ensure that they adhere to the basic minimum requirements of every health facility. That has also been done. So for us, we see that the minimum requirement quality will be as far as the setup of an infrastructure, and then also the content therein. And then that will set the basis or the foundation for providing quality services. And I would like to call this more or less like access, and the Health Facility Regulatory Agency ensures that each facility, depending on its level, whether it's a quaternary, tertiary, secondary, or primary, or even below that level, has the minimum requirements to providing such kind of services. I would also want to say that we have the DHIS2 that currently harmonizes all the data that we get from both public and private. A few challenges as far as the private is concerned, but we are also working at that a primary care system where the district or the primary hospital becomes the main overseer of the other lower facilities at that level, they would all make their reporting into the DHIS2 at the level of the district, which moves into the region, into the national, and ultimately ends up at the ministry for decision making. The Objective 3, which typically looks at how community, family, and then also the patients get involved in the way that services are provided. In the past, we have done the client satisfaction surveys, and now we are looking a bit more into client experience surveys and the community scorecard, which was developed with support from ALMA in 2018 currently, which is also web-based and appended onto the DHIS2, is what we use. And this works more with the community-based health planning services across the entire country at the moment, where the community members, assess the facility and provide feedback. And one good thing about it is that they have supported the institutions in a number of ways. Some of them have helped them to build walls around the facility. They provided security to the staff who work there, and then also have contributed to supporting them with the equipment, and then also a few other logistics for running the institution. So we have also looked at developing and also integrating quality and safety into pre-service curriculum. And this has been quite interesting in its implementation, in the sense that we've been able to bring a number of the deans of the various schools and some of the principals of the health facility training schools together to look at the curriculum, which is based on the WHO safety modules. And the various regulators are looking at reviewing their various curricula across the country. And from time to time, these are also incorporated into their curriculum for teaching purposes. In addition to this, we have launched what we call the revised National Health Policy by the President of the Republic of Ghana, bringing all the various health sectors together. And the focus of this one is the One Health approach into the way we work, and laterally extends into all the other agencies, ministries, and departments in the way that they do implement their work. In addition to that, as far as access is concerned, CHIPS, that's the community-based health planning and services compounds, which are I would say the units of the health system based in the community setting, has also been, a couple of them have been established to solve the geographic access issues, and then also the construction of health infrastructure is backing on what currently we are reviewing, which is the National Health Infrastructure Strategy. The government has proposed that he wants to ensure that every district, at the moment we have over 280 or so districts, that each one of them is supposed to have at least a primary level hospital from the public sector. And the strategy is going to guide us as far as access is concerned, and also to ensure that within every locality, within every district, a facility is established. And there's improvement in the population coverage with the National Health Insurance coverage, which ultimately is the main financing mechanism or tool for Ghana achieving the universal health coverage. Again, we have improved coverages with the maternal, newborn, and child health services and antenatal delivery, and also postnatal and the child welfare clinics. And then at the moment, I would say that there's also some improved doctor to population ratio, population ratio. And then Ghana is also part of the 10-country quality of care, quality, equity, dignity network. And then recently, we've also gotten to the point of having our stakeholder engagement with the 3-country study, the mechanisms to engage the private. So there's a lot of synergy, a lot of opportunity for Ghana at the moment, looking at both public and private sector to be able to meet the population needs. Just to show a few indicators, I didn't put them in graphs, but in terms of malaria case fatality, I would say that for us, under 5 malaria case fatality, we are operating between 2016 and 2018, something which is less than 0.3 or 0.3% thereabout. Maternal mortality ratio also is reducing over the period. At the last survey, for example, we had, I think, 119 or so. And then for newborn mortality, there's also some decline, but it's quite mild decline. And then a few other indicators that we also want to look at, because we're looking at equitable distribution of staff, we're looking at quality care, we're looking at access, and the doctor to population ratio, has been declining gradually until we meet our target. The next population ratio at the moment, WHO proposes that for every country, one nurse is to 1,000, but Ghana is currently doing 839. That clearly means that maybe we are doing well, but we also, when we disaggregate the data into specialist nurses or community health nurses, we have a gap that we really need to fix. And then the proportion of functional chips at the moment has also increased over the period. All these nice things that I've talked about is not without challenges. We have some existing issues that also hamper the provision of equitable health services. For example, we have challenges with inequity in terms of infrastructure, human resources, and also the financing mechanism that runs in the country. The target is to get 100% of the population to roll onto the national health insurance, but at the moment, we're still working on a number of interventions that will help this to achieve that. Of course, we also have a few cultural and religious practices that may hamper people getting quality care. Finally, I'll move on to the slide that talks about the way forward. The National Health Policy, which is the framework for One Health in implementing the universal health coverage in the country. I've said that the government is really committed to implementing the universal health coverage roadmap. And Ghana we have our own roadmap into looking at social accountability, the involvement of NGOs, and then also in terms of equitable distribution of staff to ensure quality care. We are currently working on our health infrastructure strategy that's looking at both clinical and non-clinical infrastructure within the health system, including office spaces and residential accommodation for staff. There's an agenda 111 that the government has proposed to ensure that every district has a primary hospital and 16 regional hospitals and 3 infectious disease centers in the country. Equitable distribution of these health infrastructure across the country to ensure that the population benefits from this. And then the government has also positioned itself for domestic resource mobilization for health in the country. Finally, health technology, digital health, and then also innovative technology. So I must say that generally these are some of the innovative things that Ghana is doing. This is our election year. And so by the next 2 weeks or so, we are having our elections. And moving forward, we are hoping that whatever plans that the health system has put in place would continue in the coming year. I would just like to acknowledge the leadership of the ministry, the director of PPMA, where the quality management unit is located, the head of the policy coordination unit and his team that have supported developing these slides and also to be able to make this presentation, and then also the quality management unit where I oversee. Thank you very much.
Thank you very much, Ernest. Thank you very much, Ernest, for giving us clarity on the structures, the direction, the current achievements, and where the support and challenges are in Ghana's efforts to ensure that we do have quality healthcare for the population. Thank you very much for that.
Thank you.
Before I ask, yes, thank you really very much. Before we ask the next panelist to speak, participants are encouraged to use the chat box or the Q&A box. Please send through your questions now. And then when all the panelists are through the discussion and put your perspectives into the program. So thank you very much, Ernest. Thank you very much.
Thank you. Thank you.
Good. So, Margaret, are you there?
Sure, I am.
Good. Talk to us. How is Sierra Leone? What is happening in Sierra Leone?
Okay.
Please put your video on. Please put your video on. Let's see you.
Yes.
Yeah. So unless you can put your video off if you so wish. Thank you very much.
Yes, please.
Okay. Thank you very much, and good afternoon, everyone.
Good afternoon.
Yes, I am actually trying to share my slides.
Okay. So Ernest, you need to unshare your slides.
Yes. Thank you.
So that Margaret can access it.
I think it's okay now, right?
Okay, Margaret, you can share your slides now.
Okay. Are you seeing my slides now?
Not yet. So you just want to go to share screen
I've actually gone there.
Okay. So you just click it and let's just give it a few minutes to pick up your screen. And then you click desktop and then you should be good to go.
Can you see the slide now?
No, not yet. So if you have your screen and you click share screen, you have a few. Okay, you have a few options, desktop, etc. Or you see the presentation that you want to do. Click on the presentation, and then look at the bottom right and click share. You are welcome.
Yes, I hope I am audible enough. So as I have told you earlier on, I am Margaret Mana, Titi. I am the program manager for the National Quality Management Program under the RCH Directorate, Ministry of Health and Sanitation. So if I am actually giving you, as you are aware, that Sierra Leone has gone through several shocks, but still, as a resilient people, we have still withstood the heat. So we are surviving and we manage, we are here. So like my colleague presented this afternoon, for me, I will actually want to give a brief background about the health system in Sierra Leone. Sierra Leone's health system is provided at the 3 tiers of health system, community, districts, then you have the tertiary hospitals. So in Sierra Leone, basically, we have 5 key tertiary hospitals. There is one for obs and gyne, then one for medicine and surgery, then we have one for mental health, then we have for pediatrics. So we have 23 public district hospitals, and we have several ones owned by the faith-based. So we have a country, well, during the war years or before the war, the country was relatively much more better. But when the war came, Sierra Leone has to go through like 11 years of civil war with a lot of destruction on the healthcare system, and our human resource base was also depleted, wherein we lose several health workers and some actually migrated to other countries. So if you are in the sub-region or even maybe in the West, you'll see mostly Sierra Leoneans who are there operating and they have never returned back. However, we have started seeing some green lights wherein some are opting to come back to Sierra Leone to offer their services. So within the Ministry of Health, we are currently working on our national health policy. We had the one in 2002 that was never operational. So currently we are working on the national health policy. Then we are also working on the universal health policy as well as the roadmap. So maybe in few months or few weeks time, we'll actually have it. Then that will be, they give us a clear direction of how Sierra Leone wants to attain universal health coverage. However, we have our national health strategic sector policy as well as the roadmap. Then there is an RMNCH roadmap and strategy. So maybe from that point, I will now come to my presentation, giving you that brief background. So this afternoon, are you guys seeing?
Yes,
So,
yes. We see your slide, we hear you beautifully.
Okay.
Please go ahead.
Okay, this is how my outline is going to look like, what actually drove quality in Sierra Leone and what has happened so far.
No, now, Margaret,
Yes.
you need to now tap your down button so that your PowerPoint can move.
So basically, this is my outline. This is my outline, and this is my outline. What actually drove quality in Sierra Leone, what has happened so far, then what are the implementation milestones and what the challenges are, and what I would really want to see as a country. So, oh God, what is happening now?
Now we are on your country background.
Okay, as you can see from the country background, basically Sierra Leone, as I told you earlier on. Is it okay?
Yes, yes. We are on the country background. Please speak to it.
How come I am not seeing?
We
Basically, Sierra Leone, as I have actually told you, is a country. Resume slideshow.
Can you see your slides?
Of access to healthcare as indicated by the process indicators. However, the outcome indicators are very bad. The process indicators you have seen, there is a high ANC coverage of almost 98%. Then there is also ANC4 coverage, and there is skill bat attendance. Unlike the war, immediately after the war, Sierra Leone, we have like 90 midwives as a country. But today, with support of partners and also the government, we are over like 700 to 800 midwives. And we have midwives now at community level. So with all that one, it is not actually showing in terms of the outcome indicators. And you are all aware that Sierra Leone has been classified among the countries with the worst maternal and newborn indicators in the country, wherein it is not very safe for a woman, including myself, to have a child or think of having a child. So based on these, actually, it actually moved the country for them to be able to declare, first of all, there is free healthcare in a country for pregnant women, lactating mothers, and also children under 5, because they thought initially that cost was an issue in terms of accessing healthcare. But free healthcare was declared by the previous government, and that is currently what we are operating under for maternal and newborn health and child services as a country. But with all that, the indicators still keep going up. We have not been able to actually reduce on our maternal, newborn, and child indicators as a country. So what actually came into being, that quality was an issue. Quality was an issue because of poor quality health services. That's why our indicators have not been very clear. So that actually was the impetus that drove the national quality program as a country. And in line with that as well, His Excellency, because of the poor state of quality of our RMNCH services, His Excellency, the current president, declared or actually clearly stated it in their new direction, in their manifesto as a political party, to ensure that our services in this country are of quality so that people are able to access it. So if you can see on the slide, these are his statements, because in terms of quality, we also capture statements that are political statements, and that is what we'll use as our yardstick or our baseline for us to be able to really see there's a reason for us to be here. So this is one of the milestones that
go to the next slide. Go to your next slide, please. Tap it for us.
So if I want to say, the next actually giving you, like my brother from Ghana mentioned, Sierra Leone is one of the countries that is part of the QED network, and it was actually a presidential request for Sierra Leone to join. So the other slide that I'm showing you is our effort so far.
Oh, you haven't shown it yet. You haven't shown it yet. Click.
I have clicked actually. Are you seeing? I am showing you where we have the national policies that are really going towards quality of care. Because if you look at the RMNCH strategy, it has targets to reduce maternal mortality from 1,165 that we have in 2013 to at least half of that, 650 per 100,000 live births. Then it has also a mandate to reduce the neonatal mortality rate from 30 per 1,000 to 23, and also to reduce the under 5s mortality, including the stillbirth and adolescent birth rate. As you are aware, Sierra Leone is a country that have the highest adolescent birth rate, not just the birth rate of 125, they have also contributing to 40% of our maternal deaths. So you can really see that the services for adolescents in this country is also key. And you now see the reason why the quality program is situated within the Reproductive Health and Child Health Directorate, although it is a health system strengthening initiative. So for us in Sierra Leone, that's why we categorically pushed our quality program within the RMNCH. And also, if you see, currently as a country, we have now a national definition for quality that you can see on the slide. And the document that you see, it is RMNCH, the Quality of Care RMNCH Strategic Roadmap. This is what we want to do for the next 5 years as a country for us to be able to attain our targets that are set within the document. And we have established the program, and I'm currently sitting in my office. Then I, as the program manager, and I have key technical staff that I work with. Unfortunately, they are on the field, and I'm sure they have joined from the field. Firstly, we have a governance structure. We are using the global strategic objective structure to have our own outline as a country. So in terms of governance, there is a national steering committee that has been established in 2019, and that one is chaired by the chief medical officer or the Minister of Health and Sanitation. Then the director RCH is the secretary to that committee. So this is a picture that was taken from one of the sittings that they have. This is the highest body that actually is providing oversight in terms of quality. And it comprises of directors, program managers, and key partners that are engaged in the quality journey. Then the second one is the National Technical Working Group that was established. They have been meeting. These are the technical people who comprise of, we have our partners, we have people from all the other directorates or units that have a stake in terms of quality. And these bodies have been meeting. They actually provide technical oversight for what will happen in the quality space. Capacity building, of course, has been done. Several trainings have been done for health workers in improvement methodologies for us to be able to really see what our issues are, what the challenges are, and how we mitigate some of them. I think one of our colleagues who are online volunteered to come to Sierra Leone, even when we had issues with Ebola. So he has been part of us, and we want to say thank you for his support so far to this country. My slide is moving. Is it okay now? Are you seeing?
We are controlling it from here. Okay. So tell us where you are, and then we'll let you speak.
I am now on capacity building, so I think we have to go to the next slide, please. Thank you.
Welcome.
Yeah. So from there, we have actually identified Sierra Leone has over 1,000 health facilities, but currently we are using 25 to provide. These ones we have actually identified as learning facilities, and they have been identified, and we have teams who are currently working. Can we move, please? Okay. So the previous slide, on that slide, actually, we have QI teams in these facilities that are really overseeing the day-to-day QI projects within those facilities. Sensitization has been done with of partners on QOC. Then experience of care tools have been developed, and we piloted in one of these learning facilities. Results are out as well. Can we move, please? Thank you. And we commemorated as a country for the first time the World Patient Safety Day. And during that, several activities were actually earmarked, but the climax of it was the launch of the RMNCH Quality of Care Strategic Roadmap, as well as the QOC policy. So if you see on the slide, that is me that was actually giving an opening statement and welcoming people. And it was launched by the Honorable Minister of Health and Sanitation. And if you look on the slides, that's what he is having in his hands. Next slide, please. So I am just showing you the global dashboard that Sierra Leone has been contributing. So this is how the dashboard looks like with all the countries in the QED network. And this is, if you look on the dashboard, this is what Sierra Leone has been reporting so far. Next slide, please. Now the key challenges. amidst all what we have done in a year, because we are just like a 1-year-old baby, we have series of challenges that we have been seeing, and I am very hopeful that some of these in 2021 we will be able to mitigate some of them. There is lack of a national quality commission, like my brother was saying from the other countries. We are yet to establish it. Then the effort in terms of quality, it's fragmented, it's varied, and the initiatives are a bit there is not much synergy between them. So we are yet to see that. We have issues with HRH in terms of numbers in mix, and also there is a lot of volunteer. We are using a lot of volunteer thanks to the current government that has been able to at least recruit over 4,500 healthcare workers. So currently we are very thankful to them. Then there is integration also is an issue. Then the issues around laboratory quality, then patient safety issues in terms of medication safety and also safe surgery. Then we have issues around quality assurance and control. As a country, the regulatory systems are very weak. There is limited finance for the entire healthcare system. Then we do not actually have feedback from clients, and we do not have patient charters, and their rights are a bit not very well defined. Then community engagement is yet to happen. Then also some amount of social accountability. Can we move to the next slide, please? These are some of the challenges. Well, for way forward, I am actually saying, because it is believed that when you are silent over quality issues, you are actually like appending your signature for millions of Sierra Leoneans to die, and even other foreigners that are within Sierra Leone. So because we don't want to see that, we are yet to really establish and strengthen our data management system so that we'll have quality data that will really transform into policies as well as a decision-making or into practice. That's we are yet to see. And we want to organize a national learning forum wherein these projects that we have been having in these learning facilities, we can showcase so that change packages can be developed. We want to really adapt some of the best practices in other countries that have really helped them in terms of like the client or patient charter, and also see how we are able to strengthen the regulatory systems. If you look at Sierra Leone, our regulatory systems are a bit ineffective, although they are trying their bit, but we really want to see it more robust and it's really moved towards the line of accountability. Then we want to establish a quality commission, which will serve as a legal system as a country. Then we want to conduct our patient safety assessment as a country, because currently we are under the COVID-19. So we want to see what is it that we really have to benchmark on. Then we want to see, like our colleagues have done, how we include quality in pre-service education as well as the in-service one. Move to next slide, please. Conclusion. Before I conclude this afternoon, I really want to extend my gratitude to the Ministry of Health and Sanitation, my director, the Honorable Minister of Health, and also the government, because currently there is that political will to drive on quality. So before I end, I want to say quality is everybody's business. Let's continue to speak about quality, patient safety, and let's explore opportunities for improvement. Also, let's take quality as my personal business. So that at the end of the day, we are able to save millions of lives for Sierra Leone, and we'll be able to have our economic development as a country and growth. Then the country is able to say our survival rates have increased. So at this point, I want to thank AfIHQSA for giving me this opportunity for me to share a 1-year-old journey in terms of quality on Sierra Leone. And thanks to Dr. Elom, who actually was part of us in this journey. And also my brother Boku. Thank you very much. So if I may stop so far, this is the journey for Sierra Leone on quality. And thanks to our audience who are online. So at this point, I would want to say thank you and to ask for questions. If you have questions, if you have comments, or you need anything clarified.
Thank you very much, Margaret. Thank you very much, Margaret, for the insight. And like you said, 1-year-old baby, we do appreciate your honesty and the authenticity of your submission. What I found exciting was the fact that your drive was based that your processes are working, but you are not getting the outcome that you want. So let's hold our thoughts. A few questions have come into the Q&A box. Participants, you are encouraged to put your questions there. I will now call on Andrew from Malawi to share with us your experiences in Malawi on your journey towards providing quality care to our brothers and sisters. Please go ahead, Andrew. Thank you. Over. So Andrew, we see your screen. Now you want to unmute so we hear your voice.
All right. Okay. Good evening. It's evening here in Malawi. I hope it's evening in Ghana and other places, South Africa. So I want to greet you in a special way on this specific and great day for Africa. I hope you can hear me quite well.
Yes, Andrew, we can hear you very well. Please proceed.
All right. Thank you. Thank you. So I will briefly give you an update on the status of quality in Malawi health system. So this is a journey, a 4-year journey that started in 2016. And I want to commend all the colleagues that have been contributing to the work that I am going to present this evening. So as a matter of background, Malawi is a landlocked country with a population of 19 million. And from the Millennium Development Goals, 15 years of implementing the goals that were set during the Millennium Development Goals, we noted a lot of improvement in terms of child health. And also I must indicate we saw a lot of improvement in terms of access to health services, especially for pregnant women. As you are aware, there were a number of policies. We were working to reduce maternal mortality in Malawi, but then we had about 675,000 per 675 per 100,000 maternal mortality ratio. That was when we are just clocking 2,000. But by 2015, we had a maternal mortality ratio of 439 per 100,000 live birth. So clearly, we saw I would say a minimal reduction in maternal mortality. But one key thing that we saw was improvements in terms of women that were attending, that were delivering in health facilities. So deliveries within our health facilities moved from 74% to 90%. In essence, almost 9 in every 10 women were delivering in health facilities. And delivery by skilled health personnel also moved higher. Also, so deliveries at facilities moved from 64% to 90%, while deliveries by skilled health personnel moved from 74% to 90%. So in essence, 9 women out of every 10 pregnant women essentially were delivering in health facilities and delivered by skilled health personnel. Now, the challenge was that still the mortality was quite high. As we demonstrated, you will see that our mortality, maternal mortality, was at 439 per 100,000, despite 90% of the women delivering in health facilities or accessing services, despite the fact that 90% of the women were delivered by skilled health care. Now, in essence, what we saw was a puzzle. We had a hypothesis that women were dying at home. The maternal mortality was high due to deliveries by unskilled professionals who were called traditional birth attendants, but we banned them and we strengthened institutional delivery. Although we did that, essentially, it did not give us what we expected. The outcomes were still not quite good. So essentially, this motivated Malawi to move into the quality agenda. So this is the hallmark for us to be talking about quality in Malawi. So it was noted that I think the missing link between the good input that were set and the bad outcome that came out, the missing link was quality. So this drove us to come out with a clear definition of a local definition of quality. And I must indicate that I think from my experience, there is no single right definition of quality. Quality can be well defined by a customer or consumer. So how I perceive quality may be different from how another person will perceive quality. So quality has to be defined and made based on the definition that a customer is sharing. This is very, very important, considering that we always want to measure whether our clients have been satisfied with care or not. So how health workers craft quality definition may be different from what patients are expecting or what patients define quality. A patient may define quality maybe just as a mere greeting. So a patient may come to your facility and they find out that you haven't greeted them. They will get treatment that you offer, and still they will not be satisfied just because they were not greeted. A patient may just, some may, to them, quality is clean toilet. So you may do everything right to the patient that you think is right. But if you don't provide a clean toilet, they may be frustrated just because they did not meet what they expected. So it's important always to find out clearly from a patient what exactly matters in their life, what exactly define quality as far as they are concerned. And we strive towards achieving that. So for Malawi, we noted that I think we needed to come out with a policy and a strategy. A policy helped to integrate because every donor, every partner, they were implementing things in silos in Malawi. We had so many implementation structures, programs were implementing their way. Some of the quality providers had different names. You would hear someone saying, you know, I'm a quality champion. Another one will say, no, this is a quality coach. This one is an advisor. This one is a mentor. So many names. And there was a big confusion. So we had to come out with a policy to streamline and agree on how bringing structures together. At the same time, also, we had to develop, within implementation of a policy, set up structures for implementation. So at national level, a department of quality management was set up. We have focal persons who are coming from various departments. So deputy directors for every department, let's say nursing, clinical, both whether it's a support program, every deputy director is a focal person for quality. So we have this to make sure that quality is streamlined within even the departments at national level. We have a technical working group for quality, which meet every quarter. And at the district as well as facility level, we have focal persons. So I must indicate that to make sure that this is sustainable, in most programs you hear about coordinators who are just assigned. But now here in Malawi, government has put up an establishment for these focal persons so that their work is fully dedicated to quality. So there will be quality officers working 24/7, just doing quality, not other jobs. Also, we have quality improvement support teams as well as work improvement teams. There are a number of interventions that we've worked on so far. I must indicate that the department has got 3 divisions. One division is responsible for setting up norms and standards. The other division is responsible for coming up with interventions, quality improvement interventions. So it is responsible for patient safety, any quality innovations that are needed to come in. So the final division is responsible for quality assurance and all measurements that are needed. So I must indicate that we are working towards setting up local standards, quality standards, and also working with regulatory bodies to make sure that they have got a unified and strengthened role. Also, we've been implementing various initiatives. We'll highlight patient charters, service charters. This came in as we were defining quality, and we wanted to make sure that we are realistic in meeting the expectation of patients. In most cases, patients come blindly in our facilities. They don't know what to expect. So we wanted to clearly define what we can offer on our supply side so that when patients are demanding, they exactly know. So all health facilities in Malawi have got patient charters, service charters. And also we wanted to make sure that complaints from patients are not shared through social media, but they should be attended to right there and then. So we have a complaint mechanism at every facility in Malawi. So we set up what we call hospital ombudsman, and these people are located to receive complaints and address those complaints accordingly. As Ghana has indicated, we've got also in Malawi is one of the countries that is in the quality of care network for maternal and newborn health, and the ultimate goal is to reduce mortality, maternal mortality as well as neonatal mortality by 50%. That's institutional mortality within 5 years. So we are targeting 2022. So for Malawi, we have a framework as well as a roadmap and implementation guidance in terms of working towards reduction of mortality by 50%. And we are also working on the medical legal program. We know that the moment we raise up the quality, we raise up the demand, litigation will be the normal setting. So we need also to prepare health workers to know what it takes. When the quality goes up, we shouldn't, when the patients are well informed about their rights, we should also expect that litigation will come in. So medical legal is another area that we are working on at the moment. I already raised about the quality assurance. This is also a division that is responsible. We've been setting up accreditation in Malawi. We are working with COSASA to pilot accreditation. This is the second phase of accreditation. We've seen improvements in a number of areas in most facilities that are participating in accreditation. Of course, our experience has been that faith-based facilities are doing much better than the public government facilities. I think there is a huge, really big discordance, and we want to find out why is it the case. We have also developed the health situation room, where most of the indicators are seen. You are able to see the indicators, performance of various indicators, even on phone. And I think a great landmark is a dashboard that we've developed that is live for all MNH indicators. Whenever there is a near miss, maternal near miss in every hospital in Malawi, we get a notification in real time, as well as when there is a maternal death, when there is a neonatal death, even with COVID, if there is a pregnant woman presenting with COVID-19, we're able to get notifications accordingly, and the dashboards are live. So there have been some challenges. The stories have been just rosy. Some mostly have been system challenges, like human resources for health. We can't talk about quality of care when there are no bodies to provide that service. So huge staff shortages. And I must indicate here that mostly what we've observed, I'm not sure with other countries, but in our case, normal establishment is not based on quality. Establishment, they will just determine, okay, district hospital have 10 medical doctors, but that's not that's not a quality issue. So in Malawi, we are pushing to make sure that quality drives establishment for human resource. Want to make sure that at least we should be talking about cadre related ratios. So how many patients should be seen by one nurse, for example, in a labor ward? How many patients should be seen by a specialist or a surgeon? So we should be talking about numbers so that we can easily talk about quality, rather than just giving vague numbers to inform establishment, and there is no basis for that. So the other health system related challenges are inadequate equipment, and in some cases even drug supplies shortages. So those are routine challenges that really impact negatively on the services that are being delivered. Leadership for quality also has been an issue. I must say that quality is all about leadership. You can't get quality where the leadership is not talking about quality. So bringing in leaders that can champion quality becomes really a huge challenge. And I would really, I think this is something that I think for countries that are thinking about setting up quality programs, I think is something that you need to really strongly think about. Resistance from other programs, mainly vertical programs, like malaria, TB, they would want to talk about quality, but maybe integration is becoming very difficult. Others to perceive and say, no, this new department is taking up our roles, because maybe some of the roles were carried over by other departments. So that's another challenge that I think we've been facing. I must also indicate that sometimes what patients demand is not what we are able to offer, mostly in health facilities. Also, what patients want and what the health system want, normally there is a huge discordance. So I'll give an example that sometimes when you go to a facility, you find out that patients are queuing to get registered instead of queuing to go into a consultation. So most of our systems are paper-based. People are queuing, spending most of their time queuing to get registered. And most of the focus is about data. We want to count how many people have come. So I'm not negating the need for data or measurements. You can't in any way improve without measure. But I think when it comes to patient-centeredness, patients are not coming to be counted in our facilities. Patients are coming to get care. So we need to improve so that patients are not queuing to see a computer or to get their names registered. We need to modernize the way we do things to meet what patients need. When we look at long waiting times, sometimes the waiting is just, I think, to respond to things that the health system need. A patient will go after consultation, they'll go back to the register, they go to the lab, they will queue on a register. So I think we need to be thinking about a patient. A patient should not just be queuing unnecessarily and bringing in lots of, I think, frustration in essence. Finally, human resource related issues. So I've already highlighted the shortages. I would also talk about high turnover. So you find out that you bring in someone, you train them today, tomorrow is no longer there. So there is huge staff turnover, which has been affecting implementation. And also involvement of clinicians, especially specialists. I think this has been a big issue. Some people think that quality is about nurses, but quality is everyone's responsibility. So how do we look at the future? I've already highlighted the need to move into digital. And the digitalization, when we are moving with digital health, the focus should not be data. Let's focus on improving the quality of care. Systems should be designed to improve the quality of care for patients. Systems should be designed to improve the quality of service for healthcare who are healthcare workers. So any system should be designed in a way that it is focusing on a patient first, healthcare second, and finally data will come out automatically. So we need to change. Always we tend to talk about DHIS 2, or we want to talk about data. But let's, I think, change that role. We are looking also at setting up a national accreditation body, which can be able to do local accreditation before we engage bigger international organizations like COSASA. So plans are underway. We are working on this. We are also looking at mechanisms to sustain and enhance quality culture in our setup, so that quality is a talk of everyone. Finally, we want also we are looking at setting up systems that are patient-centered, as I've already indicated. But I must indicate that we need to move with standards to drive improvements. Standards should drive improvements, and at the same time, improvements should be measured to ascertain whether we are really on course. I must finally say that quality should be personal. I want to agree with Margaret. We are setting systems that save ourselves. Today, we know each other. The system knows us. If we get sick, we can get faster care. But time will come when we will have to face the same system that we are working on today. So I want to encourage everyone to take quality personally. If you want to use good toilets at a hospital, abolish the staff toilets today so that everyone, staff or patient, uses the same toilet. And for sure, when you come as a patient one day, you will not regret that you were sidelined or you used the toilet that was not well prepared. So quality is about ourselves, setting up a system for ourselves, and let's be very selfish, let's be personal. Thank you very much, Gilbert and team.
So thank you very much, Andrew. Thank you very much. Thank you very much, and all the other presenters. So if our panelists can all come on video, let us see you all and appreciate you. Margaret, Ernest? Yes, Ernest. You know, we in AfIHQSA, the intent is to have panel discussions like this from across the continent. And I want to believe that the richness of the presentations, if we're able to let it sink in, we can all appreciate, and we can see ourselves in the different scenarios and the different efforts that have been put up. There are a few questions that have come in the Q&A box. I will encourage participants to go to the Q&A box. I'm not going to read them out again. So just go there, have a look at it. If your question is not there and anybody wants to raise a hand, please do so. Or anybody wants to put a new question in the chat box or the Q&A box. Some of the questions have been answered adequately. Please have a look at it. So we use the remaining 15 minutes or so that we have scheduled for other real life interactions. So if somebody wants to put their hand up and wants to put their voice in the space, please do. I'll ask our panelists to just reflect what would be your core message, that one single message you want to give to all of us on this continent. Think about that as we get a few other questions, and then we will take your last words or your comments to the questions before. So please, participants, look at the Q&A chat box. A few questions have been put there, answers have been provided. Look at the main chat itself, and if there are any questions there, please have a look at the responses that have been given. For a good number of them, that has been done. And we are getting the feedback, exciting and interesting. Patrick Amenya, please, you can unmute yourself and speak to us. Patrick Amenya, you can unmute yourself and speak to us. Yes, please go ahead. You need to unmute yourself, Patrick. You are still on mute. We are also getting used to this virtual world. Patrick, you need to unmute yourself. Okay, if anybody else would want to put their voice into the space, please raise your hand. We will give you permission, and then you can speak into the space. Okay, Patrick has said exciting and interesting, so he has spoken through the chat box. You know, we've had presentations from countries at different levels of engagement in their journeys in quality. We have those who were born yesterday. Margaret, she's already smiling. We have those who were born yesterday. We have those who have been plodding on for a long time and still moving ahead. And therefore, they looked at the real high-level policy structures, national strategic plans, etc. And we have the Andrews of the world who were not born yesterday, and who are, or they totally were not born yesterday, and who are speaking from the ground and giving us much insight on what the real issues on the ground are. I take away from Sierra Leone, I looked at your challenges and the way forward, and I think if we just study that and convert them into interventions, we can all pick significant things we can do in our own countries. Yes, most of us are starting the journey blind. Quality is a nebulous space, but I like what Andrew said, we need to take it personally. And the truth of the matter is, right now, we're all well connected in the health space. We know everybody. So I just have to call Andrew, I'm sick, and Andrew will organize magic and I'll be seen by the best. But when both Andrew, myself, Ernest, Margaret, Elam, and all of us on this platform have been retired for 3 to 5 years and nobody knows you, how will the system treat us? How will the system receive us? And I think that should be our primary concern. Like Andrew said, we should be selfish to make sure that the systems and the institutions deliver the quality we ourselves would like. I take note from what Margaret said. All their processes were happening well. We are strong on process and activities on the continent. Number of meetings, number of outreaches, number of clients seen, and that is the core of our reporting. But if we shift to what Andrew is alluding to, we'll be more interested in the outcomes we are achieving and realize that with all, it's like standing at a parade and marking time. We are spending energy, but we are not moving forward. And I was excited with Margaret putting it out there, 95%, 98% coverage. But when you look at the results we are achieving, then we realize that there's something wrong. There's a mismatch between the energies and the activities All three speakers clearly recognize the role of high-level leadership, the ownership at the top. This is not a bottom-up process. Quality is a top-down process. Quality is a top-down process. And for those of you who are in operations, you know that if the ward in charge is not interested, forget it. You know that if the hospital director is not interested, forget it. If the minister is not interested, forget it. Most of us speaking here may be in that space, and if we are not, you are encouraged to advocate and get to those in leadership. Doc, I think you should ask some of the questions. You know, I'm being asked to ask questions. The only question I'm going to ask of the panelists to wrap us up would be, what is their final message to all of us? We will share the presentations. We will share the presentations to all those on the call. You are encouraged to look at the presentations and take for yourself what is relevant to you and what syncs with you. AfIHQSA is also encouraging you to contact the panelists for the different things they are doing and they have done. There are certain things that came up to me. For instance, when we were talking about the medical legal situation that is going to happen very soon. When people now become more aware of their rights and what they should expect, some of us will go and do law and then go into medical legal and just wait, because it's going to happen. Andrew, it's going to happen in the next 5 to 10 years. It is happening in Europe and America only because the people are so aware of what they should expect and they demand for it. So in as much as we are improving the quality, we should also be mindful. We should be mindful that a whole new kettle of worms are going to rise up, and we should be ready for it. Not ready for it by denying ourselves, but ready for it by preparing ourselves to ensure that we meet the expectations of those who we provide services to. Yes, so we have 5 minutes to go. Ladies first. You see, Margaret, I don't want them to say what you want to say. So I'm going to let you say something first so that the others have to change what they have to say. So Margaret, what would be your advice? What would be your recommendation to all of us on this call where making sure we provide quality of care to all our people is concerned? What would be that one single input you want to make into us? Over to you, Margaret.
So I want to say thank you again for this opportunity and also giving me the opportunity to say my last word. What I would like all those who are listening to us and including us to realize that today you are not a patient, you may be a client that wants to be treated fairly, wants to be given dignified and respectful care, and wants to be like the emperor in the room. And the other thing I want people to realize that today you are like this, you will die one day. But at least let that death not be something that you acquire. Let it be a death that is really inevitable. Not me coming to your facility today, then you give me something that I did not come with. Then also let's price quality. If we don't put quality at the forefront of our healthcare services or even our education or whatever we have to do in terms of healthcare, that we always know in terms of quality, healthcare is an enterprise. If we don't ensure quality, meaning we are also appending our signatures to the death of the millions of people that we count. Let's stop counting the numbers. Rather, let's see how we will be able to save their lives so that they will become the Margaret today that is presenting on behalf of Sierra Leone. If they have neglected me, if I was not treated nicely or taken care of, you know, even though with all the shocks, I would have been dead and gone. And once somebody has died, that person will not come again. Then when somebody has become morbid, that person, it will be very challenging and a very difficult moment for the relatives. So whatever we are doing today, let's think quality and let's put people into the shoes as we want them to treat us in future. So I want to say thank you.
Most welcome, most welcome. Thank you very much, Margaret. Andrew, let's hear from you.
Yeah, I think what I would say is that the future of healthcare is quality. So it's quality. We have to talk about quality, and quality should be the agenda for everything we do. Let's talk about quality. It's possible. Let's not doubt about the capacity that Africa has. We can set up a quality system based on our context of the definition of quality. So quality is the way to go. Thank you very much.
Thank you very much, Andrew. Ernest.
Yes. So my last words will look at two sides. One of them will look at the role of the provider. I think for us providers, it's important that we put faces behind the statistics or the figures that we are looking at. And to know that these are real human beings that are dying, that are morbid. And so we need to attach some importance to it as far as experience of care is concerned. On the side of the patient, the community, and the family, I would also want to encourage them to demand quality healthcare. I think that we have talked about the fact that moving into the future, there's going to be some medical legal issues and things like that. But I would propose that if you die before someone is suing, it might not necessarily bring back the person to life. So once we are alive and we are physically there with the people providing service to us, it becomes our responsibility to participate in the care that we are receiving and to demand quality care so that ultimately we can be healthy and we can be alive. Thank you.
Thank you. Thank you all very much. Margaret from Sierra Leone, Andrew from Malawi, Ernest from Ghana, all of us from Africa. We have the same passion, and AfIHQSA is intent to have similar sessions like this once a month. We will move from policy discourses to operational to learnings. We encourage you to get in touch with those who you've seen on the call when we send you the material, and let's start from each other and not reinvent the wheel. As Margaret is saying, we may be a patient one day. As Andrew is saying, leadership is key. Let's not forget. And as Ernest is saying, hey, either which way, it is important that all of us keep the patient in our line of sight as we continue as healthcare professionals. And all of us are encouraged to talk about quality, talk about quality, talk about quality. We'd like to thank you all for your time, your participation, the panelists. AfIHQSA is extremely grateful to the participants. We are really happy that you made it. Please share the word. When you see the invitations again, hey, join. Let us share knowledge. Let us share knowledge and share experience. Thank you all. Have a pleasant morning, afternoon, evening, or night, wherever you are. Bye.
Thank you. Thank you, AfIHQSA. Bye-bye.